Hi there, my name is Roger Pillemer and I'm an orthopaedic surgeon with a particular interest in impairment assessment. In this series of talks, I would like to discuss the examination of the hand. At the outset, it is important to distinguish between two different types of examination. The first type is a systematic examination, which needs to be carried out in every case. The second type is a specific examination where we are looking for particular conditions such as carpal tunnel syndrome, de Quervain's tenosynovitis, various instabilities, etc. It is helpful to deal with each of these as almost separate entities. Even more helpful, however, is the need to understand the anatomy and physiology of the tests that we are going to carry out, which then makes for an appreciation of why we are doing these tests in that particular fashion. For example, one of the tests we do to assess ulnar nerve intrinsic function is to test for the power of adduction of the fingers. This is done by getting the patient to place the hand flat on the desk and then asking them to try and hold a piece of paper between the fingers while the examiner tries to take the paper away. In ulnar nerve lesions, patients lose this power of adduction and are unable to grip the paper. Why is it important for the hand to be placed flat on the desk? Well, if you flex your fingers down into the palm of the hand, you will see that they come down in a parallel fashion. However, if you flex each individual finger, you get a different picture. The fingers all flex towards one specific point in the distal forearm, about 5 centimeters above the wrist, so that as the fingers flex towards a fixed point, they actually develop an adductor force. Try this out on yourself. Place the piece of paper with your hand flat on the table and try and take the paper away, and then raise your metacarpal hairs 1 centimeter off the surface, and you will note the significant increase in adductor power that is achieved. The only way to avoid this is to make sure that you have the hand flat on the desk. As you will see when we eventually get to the systematic examination, this does not take much time at all. However, as suggested previously, an understanding of the anatomy and physiology makes for a far more meaningful and enjoyable examination. Part 1 of this talk, I will therefore revise the anatomy and function of the structures making up the hand. In Part 2, I will suggest a routine method of carrying out a basic examination of the hand, where you will now have an insight into why we are doing each test. In Part 3, we will discuss specific conditions and injuries of the hand. Anatomy and function. The hand is an amazing structure, and as Jack Last points out, it is a grasping mechanism combining great strength with finely controlled accuracy at the same time as serving as the chief tactile organ. This slide demonstrates the space taken up in the sensory and motor cortices of the brain of the various body parts and shows the relative importance of the hand, the lips and the tongue. The hand is so important that if one has an amputation of all the digits at the level of the MP joints, AMA5 rates this as 90% impairment of the whole of the upper extremity. The function of the rest of the upper limb is in the main simply to be able to place the hand where it needs to be to carry out its function. And please note that the thumb is regarded as being worth 40% of the hand, that is 36% of the upper extremity and 22% whole person impairment. So let's start off with the anatomy. The structures we need to consider are the bones and joints, the ligaments that stabilize the joints, the muscles and tendons that move them, the nerves that make everything work, and the blood supply of the hand. This is the skeleton of the hand, and the important landmarks to point out are the scaphoid and the lunate bones of the carpus, and the carpometacarpal joint of the thumb, which is a very special joint allowing rotational movements as well as flexion, extension, abduction and adduction, and is also very commonly involved in arthritic change. This is the tip of the radial styloid, and this is the base of the first metacarpal, both readily palpable, and the space between them is known as the snuff box. Also, please note that if you draw a line through the distal radial ulnar joint, you will strike the lunate. I will come back to this later. This shows the important soft tissue structures that are so commonly injured, namely the scapholunate ligament and the triangular fibrocartilage of the distal radial ulnar joint. Here there is an incomplete tear of the scapholunate ligament, but when there is a complete tear, one gets a separation between the scaphoid and the lunate, as shown in the next slide. Here you see the wide separation between the two bones where there has been a complete tear of the scapholunate ligament. Note also how the plane of movement of the thumb is at right angles to the plane of the fingers, and you can check your own nails to confirm this. There are a number of important landmarks which you can readily confirm on yourself. At the level of the wrist anteriorly, there are two easily palpable bony prominences, the scaphoid at the base of the thenar eminence and the pisiform on the medial side of the wrist. Another important landmark is the snuff box, where in days gone by, gentlemen used to place their snuff prior to inhalation. This is on the radial side of the wrist, so that when you actively extend your thumb and place your index finger in the gap between the extensor pollicis longus and abductor pollicis longus, your finger falls into a depression. The bony prominence proximal is the radial styloid and distally is the base of the first metacarpal. So keep the tip of your index finger in the gap, slide it proximally so that one half of the tip of the finger is against the radial styloid and the other half still in the gap. If you now deviate your hand to the ulnar side, you will readily palpate the now prominent scaphoid abutting your finger. Keep trying until you're assured of this. The lunate, so named because it is crescent moon shaped, and the scaphoid are readily palpable on the dorsum of the wrist. It is possible to palpate the scaphoid and lunate bones on the dorsum of the wrist. These are felt just distal to the distal end of the radius, where we have two palpable depressions. To find the first depression, which relates to the dorsal aspect of the scaphoid, extend a line down between the second and third metacarpals until you reach the distal end of the radius, and you'll feel the depression. With the tip of your index finger in the depression, flex your wrist, and you'll feel the dorsal aspect of the scaphoid abutting your finger. To find the more medial depression, which relates to the dorsal aspect of the lunate, extend a line down between the fourth and fifth metacarpals until you reach the distal end of the radius and the adjacent distal end of the ulna. As noted in an earlier X-ray, this is in line with the lunate. Once again, put the tip of your index finger in the depression, flex the wrist, and you'll feel the smooth, rounded lunar surface quite easily, particularly when you go into forced flexion. Once again, these structures are best felt with the tip of your index finger. Keep testing until you're sure you can feel both bones, and so onto the muscles and tendons. It is important to distinguish between two groups of muscles that move the joints. These are the extrinsic muscles, which are right outside the hand and insert into the hand, namely the flexors and extensors of the digits. The long flexor muscles provide the power of the grip. The other group are the intrinsic muscles, which both arise and insert in the hand. These muscles and tendons provide for the finer, skilled movement of the fingers. So, the extrinsic muscles. Let's start off by examining the long flexors, of which there are 2 to each finger and 1 to the thumb. That is, 9 tendons that pass through the carpal tunnel with the median nerve, as shown here. The deep muscle of the forearm is the flexor digitorum profundus, with each tendon attaching to the base of the distal phalanx, so that when the muscle contracts, it causes flexion of the distal interphalangeal joint, with the fingers flexing into the palm of the hand. As you will note when we come to testing for these muscles, while the tendon to the index finger separates from the other tendons in the forearm, the medial 3 tendons to the middle, ring and little finger only separate in the palm, so that these tendons do not have independent function. Try and fully flex your ring finger into the palm using the profundus tendon and flexing the DIP joint, without flexing the middle and little fingers. You will see what I mean. It can't be done. Lying on top of the deep flexors is the flexor digitorum superficialis, and these tendons insert into the middle phalanx of each finger, causing flexion of the PIP joint. These tendons all act independently. This diagram shows how the superficialis tendon splits before inserting into the middle phalanx, and thereby allowing the deep flexor tendon to pass through the gap and insert into the base of the distal phalanx. So how can we differentiate between the action of flexor profundus and flexor superficialis? Testing firstly for the profundus tendon. By keeping the PIP joint in extension, you thereby prevent the superficialis from flexing this joint. And the only movement that occurs is at the DIP joint, and that is due to the action of flexor digitorum profundus. And this is carried out for each of the fingers. One tests for flexor pollicis longus in the same fashion. How do we then test for flexor digitorum superficialis? As noted, because the tendons of flexor digitorum profundus do not have independent function, if you hold 3 of the 4 fingers in extension, you eliminate the function of the profundus tendon as shown here, with all the flexion occurring at the PIP joint. You can see how floppy the DIP joint is, indicating that the flexion is being caused by superficialis alone. Once again, test for each finger individually. Remember that flexor digitorum profundus to the index finger often separates higher up in the forearm, and it may be able to act independently. This can often be partially overcome by hyperextending the other digits. Testing for extensor muscle function. Did you ever play this game as a kid where you get somebody to flex the middle fingers and place them together while extending all the other digits? And then telling them if they can separate the fingers, that means yes, and if they can't, that means no. You then ask them 3 straightforward questions where the answer is yes, and point to the thumbs, and to the index fingers, and to the little fingers. And you then ask them a very embarrassing question and point to the ring finger, and you see they cannot separate the fingers. Did you ever wonder why this was the case? Well, within a few minutes you'll know the answer if you do not know it already. This slide shows the extensor tendons of the fingers, all of which are supplied by the radial nerve, as are the extensors of the wrist. Here you will see extensor pollicis longus, which extends the IP joint of the thumb, and secondarily extends the MP and carpometacarpal joints of the thumb. And these are the tendons of extensor digitorum communis to the 4 fingers, and you will note that they are interconnected bivinculi in a variable manner. As with flexor digitorum profundus, the extensors to all the fingers function together, so it would seem that one cannot extend the fingers individually. However, there are 2 extra extensors, one to the index finger, namely extensor indicis, and one to the little finger, extensor digiti minimi, that allows these digits to function independently. Both of these tendons lie on the ulnar side of the common extensor tendons to the index and little fingers. So the thumb, index and little fingers all have independent extensor function, but not the middle and ring fingers. So when you hold all the digits in flexion, you can independently extend the thumb, the index and the little finger, but not the middle or ring fingers. The only extension that occurs is caused by intrinsic function, hence the inability to separate either the ring or middle fingers in the childhood game. So we now have 3 extensor functions that we can test for, namely extension of the wrist, extension of the fingers and extension of the thumb. We will continue discussing intrinsic function in the second part of this talk.